Back from lunch. I hope everyone enjoyed. I am here to introduce the moderator for our next panel, our last of our panels before we have our final talks and comments after this. So Dr. Judy Bass is a professor at the Department of Mental Health at the Bloomberg School of Public Health and Deputy Director of our Global Mental Health Program, Global Mental Health Center, I should say. So I will turn it over to Dr. Bass to take us through to our next panel.
Right. Hello, everybody. All right. Measurement. Who's excited, first of all, to hear about measurement? Yeah. All right. So the last day and a half, we've been hearing about the current state of affairs on the health and well-being of adolescents here in the US and globally, with a particular focus on mental health and well-being. We have learned about what the current evidence is for their needs, stressors and opportunities that are particular to the world they are living in now, and how we can and need to include youth voices and experiences in all stages of intervention design, delivery, and evaluation. There's an important push to expand availability of mental health and wellness services beyond the health sector to where you spend their time, as we've been talking about in schools, communities, faith-based services, workplaces, sports and arts organizations, and of course, online. And importantly, conversations about how to finance these services for sustainability. This final panel will present where we are in terms of setting up systems to actually measure progress and on improving the mental health and well-being of youth in the US and globally. We need appropriate indicators and data systems in order to be able to monitor, evaluate, and hold accountable the organizations and leaders who are implementing programs. This is challenging for many reasons that have been brought up already, including variations by culture and context in how youth talk about mental health and well-being, what youth want to prioritize as important outcomes, how those things change over time, and the fluidity of it all. We need trustworthy and useful data for policymakers to understand what is working and where gaps remain. So today's speakers will provide perspectives on 4 main points, and each speaker may not cover all 4 points. They'll cover sort of the different pieces of them. But the guiding areas of conversation is, what do we currently measure, and where do we need to go in the future of measurement? Thinking about moving beyond disorders, as many people have talked about, conditions and symptoms, to well-being outcomes that have come up so often in our conversations around hope, connectedness, creativity. Second, what data are currently available at the local, state, national, and global levels, and how are they being used to monitor the quality and reach of these programs? 3, how data will need to be used going forward to communicate to policymakers and to the public and with the youth themselves. And finally, what are the opportunities for using data for collaborative learning across states here in the US, across regions and countries in the global context? So with that, our panel includes Joe Ward, who is a general pediatrician. He's a consultant at the Evelina London Children's Hospital and senior clinical lecturer at King's College London. Joe Ward's research interests are in population health and epidemiology, and he uses large linked data sets to understand morbidity, mortality, and healthcare use within children and young people, with a particular focus on adolescent health. He is a commissioner on the 2025 Lancet Commission, of which we are all convened here for. He's going to be presenting. We have a recorded presentation for Joe because he's unable to join us today. Jennifer Harris, okay, I'm going to get it, Requejo, the senior advisor for the Global Financing Facility for Women, Children, and Adolescents. Jennifer supports the partnership between the Global Financing Facility and the Countdown to 2030 initiative. She previously served as senior advisor and chief of the Health and HIV unit at UNICEF, where she led teams on immunization, HIV, and maternal and newborn child and adolescent health, and coordinated cross-agency efforts on technical and advocacy products. Before joining UNICEF in 2018, she worked at Johns Hopkins, Bloomberg School of Public Health as associate scientist and deputy director of Countdown to 2030. Dr. Joanna Lai, health specialist in adolescent school and mental health for adolescent school and mental health at UNICEF in New York headquarters. Joanna is a health specialist with the UNICEF, serving as the health section technical focal point for schools, adolescent, and mental health. Her work focuses on strengthening the policy, planning, delivery, and monitoring of integrated health and psychosocial services for children and adolescents across schools, communities, and primary healthcare systems in low and middle income countries globally. Prerna Banati is a scientist in adolescent and young adult health for the World Health Organization. She is a public health researcher with 25 years of experience working in adolescent health and well-being. She currently leads research and guideline development for the adolescent and young adult health team at the WHO in Geneva. She has previously worked for UNICEF, the Global Fund, and in academia. And she is also a commissioner on the Second Lancet Commission on Adolescent Health and Wellbeing. Anna Zecharia is the Director of Programs and Partnerships and the Deputy Executive Director for, and this is always hard for me to say, the International Alliance of Mental Health Research Funders, IAMHRF. Anna is an experienced senior leader with a background in science, health, and inclusion. She brings a person-centered, systems-aware approach to strategy, aligning vision and impact across sectors. With a PhD in neuropharmacology, she has led programs, policy influence, and partnerships grounded in equity, curiosity, and care. Anna is Director of Programs and Partnerships and the Deputy Executive Director at the funder at the IAMHRF, and serves as a trustee for the UK's Mental Health Foundation. And then finally, Tracy Johnson, who was up here earlier, who is part of the Principal of Health Policy Solutions and an adjunct professor at the University of Colorado Anschutz School of Medicine. She's already been introduced, so I'm not going to go through that again. And so with that, we're going to start with Dr. Joe Ward's presentation. And I will let Asha write it.
Well, hello, and thank you very much for the invitation.
I'm so sorry. I need to share sound. Okay.
To present this work. I'm really sorry that I couldn't be there with you. My name's Joe Ward. I'm a paediatrician based in London and an epidemiologist at King's College London. And I was a Lancet Commissioner and worked with others to develop the indicators we chose to characterise adolescent health and well-being, working with all commissioners, but in particular with Kate Francis, Law Lee, Russell Viner, and Pete Azzopardi. We worked closely developing this work. So when we are thinking about the 2025 Lancet Commission indicators, I think it's really important to acknowledge that these are really building on the work from the previous commission in 2016, which identified 12 key indicators across health outcomes, risks, and determinants. And the process of identifying those indicators was really to try to harmonise them with available data, to try and put an estimate for all countries of the world for some of those key metrics for adolescent health and well-being. And to do that, we really relied heavily on model data from the Global Burden of Disease Study and the Institute of Health Metrics and Evaluation. And obviously there's lots of strengths to that, but it's also obviously clearly important to be mindful of variation in the primary data that are underlying these models. The 12 indicators were then published, populated at national level in 2019 in this paper, which was led by Pete. And then going on to 2025, we really wanted to look at progress within those 12 indicators, but then acknowledge that we did need to expand the list of indicators to capture some emerging threats, but also to just better understand key adolescent health outcomes and determinants, but keeping that focus on data availability. Where were the indicators that we wanted to explore, but had good data availability for all countries of the world. So this is a graph of mean sugar consumption by age, demonstrating the peak in the adolescent years, demonstrating the increase over time, but then crucially through the global dietary database, we were able to identify estimates for this metric for all countries of the world, and so it was included as an indicator. We considered other indicators, but didn't include them because of data availability problems. So this is then on the left, we've got the 2016 indicators, and then on the right, the 2025 indicators. And you can see then from how these have developed, so for health outcomes, we've really just unpacked the key three groups of DALYs, and now look at, in 2025, communicable, maternal and nutritional DALYs separately. We look at intentional injury and unintentional injury separately. And then obviously key to this discussion, we have a new indicator for mental health and self-harm. That's combining substance misuse and mental health disorders and self-harm DALYs within the global burden of disease studies into a separate indicator, separate from non-mental health, non-communicable diseases and other chronic conditions. We also included an indicator for self-reported life satisfaction and all-cause mortality as well. Within health risks, we kept the core group of looking at smoking, alcohol, overweight and obesity, but then we're also able to include an indicator for bullying, where there was good data availability. For social determinants, this was where there was biggest change. We looked at we added to the core indicators of not in education, employment and training, completion of 12 years of education, fertility in the adolescent years and child marriage, adding to that indicators looking at poverty in young people, consumption of high sugary drinks I mentioned, DALYs attributable to water and sanitation and air pollution, DALYs caused by collective violence, female genital mutilation and displaced population of young people. Within health policy and health systems, we added to an indicator looking at met need for contraception. We added coverage of HPV vaccine, HIV knowledge, and HIV incidence and mortality ratio. So as this process of developing the Lancet Commission indicators and building on the 2016 Lancet Commission indicators process was ongoing, WHO has separately been developing indicators through its GAMMA process, which I'm a member of the GAMMA Advisory Board, and I know members of the panel are too heavily involved in this process. But I think it's then really important then to think about what are the differences in focus and objectives of these two indicator systems. So for the Lancet Commission, as I mentioned, we are building on the 2016 indicators, and although GAMMA were informed by those, it did also have a separate, really extensive development process for their indicator selection. The Lancet Commission really prioritised data availability and use of model data in global burden of disease study estimates to populate those indicators, whereas GAMMA is really more aspirational when it comes to data needs, where they need to be strengthened, where can we identify where new primary data sources can be planned, and a focus more on primary level data rather than model data. The Lancet Commission broadly, I think, is looking at describing global trends and as local visibility and advocacy really around adolescent health and well-being, whereas GAMMA is much more focused on country-level programming. And there's important age differences as well. So the Lancet Commission obviously includes 10 to 24-year-olds, and GAMMA is focused on 10 to 19-year-olds. But then when we actually map the indicators systems across, we see real close alignment, and the ones and the red box is just related to mental health and self-harm and life satisfaction. As you can see from the Lancet Commission, we're using DALYs to measure that, and in GAMMA looking at similarly, but looking at the prevalence of depression and anxiety symptoms and care seeking related to mental health problems, and the prevalence of suicide attempts. In the Lancet Commission, we looked at self-reported life satisfaction in Gamma, looking at similar indicators, but capturing a similar concept, but using different methods. The focus of the Commission was actually then to report these at global and regional level. But we really wanted to, if you're asking like what the purpose is of these indicator systems, and what I think that is partly to describe broad global trends, but it's also looking at variation between countries and trying to understand that variation not only in current burden but also recent trends over time. So this is we've developed these visualizations in the supplementary material for the Commission, where we identified the 10th centile country for each indicator and suggested this could be a target for other locations to work towards. But really, what this visualization demonstrates is variation by sex in terms of the burden of studies related to mental health and self-harm. The lines are different countries, they're color-coded by region, and you can see the extraordinary range in terms of burden by different locations. And then if you want to then take that a step further for the indicators for mental health and self-harm, we used the Global Burden of Disease study, and then the latest iteration of that has been published this week, and then you can actually unpack that further, separating out that indicator, looking at mental disorders, self-harm and substance misuse separately, but then also for many countries of the world, including the US, looking at subnational variation. So these are just visualizations pulled from the Global Burden of Disease website, where you can then clearly see or give you broad trends around variation and burden of DALYs for these different cause groups. In terms of next steps then for the Lancet Commission work, we're going to continue to populate indicators at national level and really understand and visualize current burden variation and variation in recent change, and then use these dimensions to actually identify countries and locations where that have good progress or have challenges in progress for key adolescent health indicators, and then working with Gamma to really do a deep dive to understand what's driving those differences. We're also hoping to then examine forecast data for these indicators to understand if current trends continue, where are we likely to land in the future years without intervention soon. I'm going to leave it there, and just want to thank you again for the invitation. I'm really happy to be contacted by email, and my email address is on the screen. Thank you again. Bye-bye.
Here's up there. Yeah. Okay. Hello, everybody. So I'm Jennifer Requejo, and I'm sorry I should have given you but it's always to me an interesting because most people will look at my name and think it's a Spanish pronunciation, but it's actually Portuguese, so it's a trick. So no one knows when the name was me. So I'm very happy to be coming after Joe. Because I think he illustrates a really important point with that comparison with Gamma. The first is just thinking about the questions that we were posed, is that there are measurement needs at different levels. So there's the global level that is for comparisons, the progress assessments, looking towards targets, that sort of thing. And I would put the Lancet Commission work within that kind of global category with multi-country comparisons. And in that sense, the data that were selected, the indicators that were selected for the Commission, as Joe pointed out, were restricted by data availability primarily, because for an immediate research purpose, you can't have an aspirational indicator. You need one that has data. So that is a huge constraint and does call for the need for improved measurement activities so that global set can actually be what we want to measure rather than what we can measure. And so therefore, I think when he pointed out the Gamma indicator set has some aspirational elements in it, because it can have an advocacy purpose of driving more measurement activities, because it's sort of like we really need to know this, but we can't know it at the current, with our current instruments. So that's another really important aspect of that gamma process, was to think through what do we need and how are we going to get there. So that's kind of more at the global level. And then you have the national level or country level needs for data, which are more around the policy and programmatic decisions that ministry colleagues and others need to make. And that is also a lot of the work that WHO and UNICEF will do, is to try to provide guidance around the kinds of things to measure to support countries in their efforts to develop evidence-based projects and programs. And then, of course, you keep going down a little bit lower to the facility level and subnational levels, where there's actually need for a whole lot more data to guide clinical practice, quality assurance, and all those kinds of things. So I don't have a picture of it, but it's you all, I'm sure, have seen this data pyramid, where at the top, at the global level, you don't need 8 million indicators. You need a very small subset that gives you a really clear indication of what's going on. And then those data needs expand as you go lower down to like guiding clinical practice. So I just wanted to kind of frame that in response to the question of what do we need. So I wanted to also pause for a moment, because I've really appreciated all of the discussions around asset-based versus deficit-based kinds of indicators, kinds of thinking about mental health. So what's on the screen here is the positive sort of framing on adolescent health and well-being, the adolescent health and well-being framework. But I really wanted to give a flag, and I don't want to overlap, because I know WHO and UNICEF are presenting a lot more on these things. So we're going to have a complementary, but maybe potentially reinforcing presentation. But there was a tremendous amount of work done as well at UNICEF with Joanna's leadership, as well as Liliana Carvajal and Brandon, who was really instrumental in the development of a set of indicators called the MMAP tool, that is really helping to get a population level sense of adolescent mental disorders. And that tool set has now been integrated into the multiple indicator cluster survey at UNICEF, along with other kinds of indicators. But it was a huge effort, and I think a really important contribution to being able to improve measurement in low and middle income countries around the prevalence of mental disorders. So I wanted to put a big flag out for that work, because it's the complementary framing for the health and well-being framework. And I also wanted to flag that whole process for the MMAP development, Joanna can confirm this, was very participatory. A lot of adolescents were engaged in the validation and in the creation of that tool. So I think it really reflects the ethos of the Lancet Commission and what we've been discussing here. So now I'm just going to go over into the adolescent health and well-being framework to put it into context. There's been so much momentum in the past 5 years around adolescent health and well-being. So there was a first call to action on adolescent well-being in 2020, which was followed by the 1.8 billion Young People for Change campaign in 2022. This is all sort of WHO, PMNCH, UNICEF, and others engaged in this effort. And then there was the PMNCH Global Forum on Adolescence in 2023. So all of this sort of culminated into recognition of the need for the adolescent well-being framework to support, the definition is to support adolescents to thrive and achieve their full potential. So after all of that, there was this recognition that there needed to be some sort of measurement framework around it, so that we could actually assess how well we're doing in achieving this. And again, sort of back to the point, this was all geared much more towards a country level, that national level focus. And it is also the two other parts. It's focused on positive measures, and it also includes both objective and subjective measures. I guess it's hard to, I'm not sure if you can all see it, but just to point out that there are 5 domains that go with the individual level. So things like good health and optimum nutrition, connectedness, positive values and contribution to society, agency and resilience, learning, and then safety and supportive environment. So that is all, those are all of the components which are sort of considered to be fundamental for adolescents to thrive and reach their potential. And then there's another set that's really focused on what does the government need to do in order for these 5 areas to be realized? The other point to make here is that in addition to sort of the establishment of the framework, there are guidance documents that WHO and partners have developed to sort of translate that sort of conceptual framing into something that is practical for countries to use so that they understand how to implement something that supports an adolescent well-being framework and how to try to start to measure and monitor it. Also, as just linking back with Joe's presentation, that there is synergy. WHO and UNICEF are well coordinated on all of this, so those gamma indicators are embedded within this framework. Just wanted to point out here again that sort of next iterative step of moving to guidance materials for countries so that they have a set of resources that they can use as they think about how to implement or make actionable this whole idea around adolescent health and well-being. So there's a document that includes a tool for countries so that they can start mapping the kinds of indicators and data that they have available to assess adolescent health and well-being in those domain areas, those 5 areas for individual, and then the country government actions around policies and programs. So there's a step-by-step guide that is provided in those materials. I also wanted to just flag that there's a parallel process interlinked, a lot of the same actors all involved in all these things to try to make sure there's consistency in these materials and that there's just a constant movement forward. The other reason I wanted to show this on the global standards, there's been a process for updating the WHO global standards for quality of care for adolescents. These new standards are supposed to be published this month. And I'm part of the working group on this, but the working group, we've been reconvened to now go a step further to translate these standards into have an indicator, like an accompanying indicator framework. The point I wanted to raise here is so that you can see this concept that we talked about a little bit earlier today around lack of trying to not look at mental health as a siloed activity, but to see that it's included as a more integrative, holistic framing for adolescent health. So that's the point here of showing how the concept of well-being is really integrated into these standards of care. So in particular, I was highlighting standard 1, which is really focusing on youth engagement in setting up what kinds of care they want and need, and responsiveness to their what they're needing, and making youth services very family friendly, like very youth centered. Sorry. The other point I wanted to make here too, that we had a lot of discussions on when we were thinking through these standards, is making sure that at the center of it were adolescents, their well-being all the way across the board, physical, social, emotional, but then also trying to think about how do we also integrate the caregiver, the family aspects here as well, not to lose that that's also a really critical part of their mental well-being. So this is a little bit of a shameless plug, these next few slides, but I wanted to bring this to your attention because I think it's really an exciting advancement. So what I'm showing you here is that the World Bank hasn't historically had any involvement really, and there's been a little bit, I should take that back. So we've had our World Bank colleague here yesterday, Patricio, who was doing mental health work as part of his activities at the World Bank, but it hasn't really been a spotlight of World Bank activities. So the World Bank is undergoing the IDA replenishment at the moment, and so they've just circulated some of their high-level documents. And I wanted to point out that the point here, and it is also coming from learnings from COVID, is that there were gaps identified, and one of them is around adolescent services, which I think is huge. So I have highlighted that there. But then the next part is this one, where they've kind of even further operationalized this to saying that they want to focus both on the early childhood dimensions and then leading into adolescent services. But you can see in the box there that what they're talking about is mental health services as well, which is, again, to me, a really important expansion of the health areas for the bank. And I think it's just a great recognition of the importance of this area. So the other point around this in terms of pulling it back to measurement is that all of the projects that the bank does have huge monitoring frameworks associated with them. So I think on the one hand, this will also help drive improvements in measurement. So another shameless plug, and I am very pleased that my colleague Emmanuel is here because he's very much involved in the whole Ad Lab work, which is an initiative at the Global Financing Facility focused on adolescents. And I've just highlighted here, there are a lot of objectives of Ad Lab that are really focusing on adolescent health and well-being and a lot around adolescent empowerment and youth engagement. So a big objective of Ad Lab is supporting of implementation research in particular, but also really thinking about how to measure and learn about adolescent health and well-being in a more comprehensive way. And so I won't go through all of those points there. You will have these slides, but it's just to say that this is also another indication of the increased focus in the World Bank and the GFF around adolescent health and well-being. So I'm flagging here one of the activities that Ad Lab has been doing. They do country case, they do work with different countries and the focus varies by country. But the reason why I'm bringing this up around Cambodia is that the focus of this initiative was capacity building for young researchers themselves in the country to do research that has policy and programmatic implications, so that real implementation research focus and the capacity building of young researchers to carry that all the way through. And the important point here is that they've been able to pick their own research topics, and the majority of them have focused on mental health. So it's just, again, an indication of how important this area is moving forward. I also wanted to point out one of the projects that was embedded in the Lancet Commission that I really appreciated and was involved in, that isn't part of that indicator set that Joe presented, but was another way in which we were trying to engage young people in the commission, and that was the Youth Solutions Lab. And the way it was designed, the point of it was to have groups of adolescents convene online around the world to work together to not just do problem identification, but to brainstorm together as a group on solutions to the problems that they think are most pressing. And so I just think that's to me, like a great methodological approach for engaging young people in the whole process of identifying to them what matters most, and then also thinking with them what's going to work most, or what do they think would be the most appropriate kind of solution for those issues that's relevant for the context in which they live. So I really liked that. And then there was one part of it, of course, that they identified mental health as one of their key topics of interest. So I'm going to stop there. Thank you so much.
We go to the Zoom.
Yes.
Oh.
So we have a shared WHO, my colleague Prerna and I will do a shared presentation. She's joining online.
Show both of you.
Can you hear me?
Prerna, do you want to go ahead and start?
Yeah, can you hear me, Joanna?
We can hear you.
Excellent. So Hello, everyone, and I'll just indicate next slide. Thank you so much for sharing the slides. Uh, Good afternoon, everyone. Good evening from Geneva. I'm very disappointed not to be able to join you in person. I'm imagining an incredibly a productive and a very inspirational set of presentations and discussions. And so I'm hopeful that, in fact, there's been lots of networks and collaborations that are forming out of the presentations and the discussions that you've had over the last few days. I'm really delighted to share the stage with Joanna. Joanna's there. We're sharing a presentation on From Data to Action and Learning in our interagency collaboration approach, WHO and UNICEF working very closely together on many aspects of measurement, but also really strengthening the link between measurement, policy, and practice for adolescent health and mental health within it. So definitely we all know about the growing recognition of adolescent mental health as a global priority. And as we see this increasing spotlight shining on this important condition, it provides an opportunity for us to really think about what are the measurement and data needs for us to really advance change and action for this condition amongst young people. What we see is that often we hear there's so much data, we have so much data in countries, why aren't we using the data? But yet when we actually look closely, we find that data remains largely fragmented, it's irregularly collected, and it's definitely underused for decision making. Often it's not at the in a situation where it can be used for decision making. So there's a real impetus, I think, for us to strengthen the measurement and data operations in order for us to strengthen the decision making around policy and program change. And that's the kind of data we need. We need to inform practical steps in the field for countries, ministries, sectors to take forward around planning, financing, and then developing the accountability frameworks to people, to young people, and to make sure that, in fact, the full cycle of programs to policies and programs is maintained. Next slide, please. Yes. Oh, great. No, this is the good slide. Thank you. So the adolescent health measurement gap here, just highlighted in a few slides. What we see is that fragmented, uncoordinated measurement across countries. Definitely across countries, sometimes even within countries, pockets of groups are missing. Sometimes we get specific ages covered by specific outcomes or additional focus in some areas, for some conditions and not others. We have inconsistent indicator definitions and data collection methods definitely across country. We'll see different indicators being used. And sometimes within the same country, you'll see this inconsistent indicator definitions. Different data collection methods mean comparability is sometimes limited. We see often a disconnect between global recommendations and country level implementation. And here, there are limitations to what can be implemented in country. It requires often a translation of the global recommendations into a country strategy that can be employed with the constraints of working within a specific country environment and with the opportunities provided within a specific country environment. The translation of data into meaningful action, again, that special sauce of what do we need when we have implementation research findings or monitoring data, and how do we actually move that into active program and policies that provide meaningful change. An absence of a harmonized UN approach to country adolescent health profiles, and this is a gap, in fact, that we've been trying actively to address, and Joanna will share a little bit about that shortly. And then a siloed effort across sectors and stakeholders, again, often speaking different languages, unable to measure the same concepts because the approaches have been very different and historically different, but also not brought together in a meaningful way. And I think it's very nice, Jennifer's presentation that showed us the H6 framework on adolescent well-being, bringing together different sectoral domains, different domains of well-being and the sectors responsible for them. It's really an effort to try and bring together the different stakeholders to have a common language and a common set of measures for young people. Next slide, please. So I think part of what we... Next slide, please. So part of what we've been doing is trying to rethink what we measure. And here we have sort of been thinking about how do we move away from prevalence, the measures of prevalence, which we sorry, I think is the slide stuck? There we go. That's the one. So rethinking what we measure, I'll just keep going. Rethinking what we measure, moving beyond prevalence. Prevalence is very important, understanding sort of the situation of different dimensions of well-being, of mental ill health, but moving beyond prevalence towards these dimensions, these wider dimensions of well-being. So looking at the connectedness, and we know so many there are so many interlinkages with different conditions. I'm sure many folks have been talking about it over the last few days. Nutrition, violence, safety, many of the other domains have very strong linkages with mental health. So moving beyond the prevalence to looking also at the dimensions of well-being, other dimensions of well-being and how they link. Tracking risk and protective factors so that we can focus on prevention and early response. And I think increasingly we're seeing that this is a critical part of the mental health response, is understanding and tracking changes in risk and protective factors so that we can address these. These are practical actions that can be taken and addressed, really important to shape the trajectory for young people's well-being. Linking data to systemic drivers and determinants, again, trying to understand these. Sometimes these are a different kind of data. It requires longitudinal data or cohort data to understand drivers and determinants. Different sources of data to track and look at causes and consequences of mental ill health. And then finally, looking at the timeliness of data. And I think it's really important that we know historically it takes a very long time to collect data, and there's sometimes a trade-off there between completeness and actionability. So how do we ensure that we can actually make sure that data, quality, robust data is collected in a timely way that allows actionable decision-making? Next slide, please. Part of this is our thinking around aligning data with the audience and purpose. And again, what we've been talking about here in the framework of how we look at data investments for action requires us to look across different audiences and use different sources. In fact, it's a patchwork of different data sources to develop, to meet different purposes. So for policymakers, we need data for specific use, high-level indicators, trends and inequalities, but really for budgeting, for accountability, for priority setting, for target setting. And we have some examples there. We'll share a little bit from Gamma. We heard about MMAP as well from Jennifer. For practitioners and planners, folks who are really implementing on the ground, they need data on service quality, reach, coverage. And here again, the Global School Health Survey and YCheck are some examples that we'll share in this presentation. Again, collecting data for those audiences, for those purposes. And then finally, what do we need for young people and communities? We really need user feedback, experiences, again, for social accountability, for advocacy, and critically for co-design of solutions. And here we'll also share some examples. We have the Data to Action, which we'll talk about, an initiative that WHO and UNICEF are working on together, and the U report as well. Next slide, please. And Joanna, I'll hand over to you.
Thank you so much, Prerna. And she kind of gave an overview of why, UNICEF and WHO are really working towards these things. And so I'll talk a little bit about, how it is that we're doing it. And thanks also for Jennifer setting us up. Just a very, very brief background, on WHO UNICEF joint program, which is basically our shared effort across agencies to make, mental health and psychosocial support, like many of you are also doing, part of the everyday systems that young people and adolescents, children are interacting with. School and classroom, primary health care, family, home, community spaces, youth clubs, online digital environments. That's really where we would want to see mental health and psychosocial support, programs and services across the continuum really embedded. And the more countries that we work with, I think the more that we really see This is not about creating necessarily new or parallel systems in these countries, but working within what already exists. That's always our starting point, and where the touch points already are for children and adolescents, that's where we'll build the services, and also all of this, of course, in alignment with universal health coverage and also school health agendas. Somebody yesterday had said this, which is that, you know, adolescent health and mental health are not two separate things, and we very much agree. So our joint work, you know, around school health and adolescent health, mental health is very much part of that. It's an integrated part of that. So, you know, I think we all know there is no ideal MHPSS system that we can point to anywhere in the world. And even that, we do see there are some key elements that underpin what we feel are well-functioning systems. And so because of that, the things that we focus on across countries is governance and multi-sectoral coordination. That includes, of course, engagement of young people and other stakeholders, workforce and service delivery. Of course, quality at every level is an important part. And then today, what I'll focus talking a bit more about is the data information and accountability systems. And so I think I hope and I think the data and psychometric experts in the room will agree with me. Measurement, it does start about counting, but ultimately it's not just about that, it is about accountability. And as UN agencies, part of the mandate we have is to track the SDG indicators across countries. But it's not just that, it is also supporting countries in generating, but also using their own data to inform, you know, their, planning, financing, tracking. And I think all of us have probably worked at, service level at some point or with service providers, and we do a lot of reporting. We make a lot of reports, even as UN, we make a lot of reports, but that can't be the end of it. And I think that's a lot of what Prerna talked about, what Jennifer referred to. How do we use this data as decision-making tools and program tools? And so Gamma, which Joe and Jennifer had already talked about, just in some, a lot of people here, I think, have been part of also shaping Gamma, which is Global Action for Measurement of Adolescent Health. It's essentially an initiative that wanted to give us all common language when it comes to measuring adolescent health. That there's 47 core indicators. Yes, some of them are aspirational, but it measures across 6 domains. Physical health, mental health, protective factors, risk behaviors, enabling environments, and system responsiveness. And what it does is it would give us comparable data across countries, across regions, and that it's designed specifically so that these indicators should be able to be integrated into national systems. And I'm gonna just share, that work was years, a lot of work to get there. And now what we're focused on is an effort, and I told my data colleagues that I'm not sharing this publicly, but you'll see the profile that is launching next week. That is essentially what we call Gamma dashboards and country profiles. So of the data that exists across all of the countries that we do have, we are able to then see across those domains, which I mentioned. And alongside of that, it's important that we are doing what we call data to action workshops. You can see this photo, it's Brazil who just finished it. This quarter, also Indonesia and South Africa did it, which is really working at the country level, across ministries, across sectors, also with young people to map the data sources they have across these 47 indicators, to validate them, and also importantly, like we said, what's the mechanism for ongoing monitoring of this? Who is responsible? How can it inform health services or policy program budget? And just an example you can see in the yellow are the percentage of the indicators which they found had partial compatibility amongst their data systems, green, full compatibility, and red, no compatibility. One interesting thing I'm just gonna mention, because it was a big learning for us, is that we have age and sex disaggregated data, but Brazil has said that's not enough. You also need ethnic, racially disaggregated data, which I think for many contexts will be the same. Some, it doesn't matter. But I think that's the kind of level of effort that we'll need, to move something like Gamma into actionable tool at the country level. Global school-based health survey, I think most people probably have at some point here, researchers interacted or used this data. It's one of the most important data sources we have for adolescent health. It's collected over, I think, over 100 countries among 13 to 17-year-olds. It covers nationally representative samples, including mental health, protective factors, substance use, violence, injury, other risky behaviors. And importantly, it's a modular format so countries can tailor and adapt it. And what I want to say about that is that this data we have seen in many of these countries, it is very important for informing school health policies, and also an area of joint work we have with WHO, also UNESCO, around health promoting schools, which is the key actions and investments we have for exactly that, health promoting schools. So I'm going to then quickly jump to something more specific to mental health, which Jennifer has also mentioned. Brandon Court here is a big, long-time expert supporter of this initiative. So we have already all talked about that one of the biggest gaps we face globally in data is this data around adolescent mental health. And that's why MMAP was initiated even before my time in joining UNICEF, when Jennifer was still there. And when I came in, they had already been, well, they were still doing the youth focus group discussions and doing the clinical validation of the tool. And I remember, just to say, in terms of involvement with young people, this is not just the youth advisory, it was community-based focus group discussions. And I remember it was Belize, I don't know if you remember this one, Brandon, where there was questions around the symptomology for depression, and it was asking around the concept of emptiness. And one of the questions asked back to, I think it was a group of like 10 to 13-year-olds, around who doesn't feel empty. And they had said, oh, Chinese people. I always remember this because I'm Chinese. And I was like, really, why? And they said, because Chinese people own the grocery stores, so they don't feel empty. So why it was so important, and the kind of level of, the framing of the questions to reflect the realities and the understanding, this was very much part of the process. And subsequently, yes, there are the questions there that measure depression, symptoms, anxiety, functionality, suicidality, and also care seeking and support. And this is important because it's not just looking at who is facing these challenges, but how are they having difficulties? And also importantly, what level of access to support and care they have, because it is, especially for program and service designers, intervention designers, somebody who is experiencing, these kinds of symptoms or difficulties and has no one to talk to, is a different kind of problem than someone who is experiencing all of that and has somebody to talk to. So I think, I'm not you guys will get the slides, so I won't go over too much of the technical detail, but it started with the module, then also implementation toolkit, cultural adaptation. We were just talking about it at lunch. Even though we have a general validation done at global level, these contexts are so different, and how young people feel comfortable or not comfortable to answer the questions are so different that level of further country work is still important. And Jennifer had mentioned one of the biggest milestones, I think, for MMAP is that it was, and I don't even know if we thought that intentionally in the process, but we had the module and then advocated and tested and made it to be officially part of the multiple indicator cluster survey, the mixed survey, which is one of the biggest data platforms we have on data across, different indicators for children and adolescents. And what that does, we've been talking about it for the last 2 days, is really, allow us to link mental health with, more than 90 other indicators around education, protection, household context. And that gives so much more understanding to the context of what we're talking about. For example, in the context of SDGs, we can then explore things like, our sociodemographic characteristics like household wealth, status, mother education, et cetera, linked to mental health outcomes. Do adolescent girls who experience early childbearing across, but comparable data at population level, are they more likely to have depressive symptoms than their peers? So I think what this really helps us to do is look beyond just symptoms. Shoshana, you mentioned that yesterday, to looking at the systems around the adolescent, and importantly, again, in a way that is at a population level and comparable across countries. So I think this is passing it back to you, Prerna.
Yeah, thanks, Joanna. So Joanna's really beautifully summarized the tools and the initiatives that have given rise to how we look at data and how we move it for program to policy action. And in fact, our agencies both have really complementary mandates to respond to member states requesting for evidence-based technical support. And we can intervene in a number of ways to help support countries around scaling up and the data that's using data to look at where to target scale up, how to ensure scale up is done with service, with integrity and with quality, using human resource data to look at national capacity, looking at quality of care data that Jennifer presented, our new standards on quality of care and the new indicators that are forthcoming to strengthen national quality standards and capacity, and then monitoring and evaluating for the development and implementation of programs, and taking really a participatory approach with young people, crucially, but also with various stakeholders, including the community, parents, teachers, policymakers, and our service delivery staff as well. So really bringing these together. Next slide, please. Two examples, I think, that I'll just share very quickly, just towards the end of the presentation, but not to bore you. And of course, there's a lot of information underneath these, and I'm happy to respond to any of them. One, we mentioned a little bit earlier around the data to action workshops. We saw the Brazil example. Here's one in Ghana. Again, it's a change initiative that is that aims to generate information from students currently in 4 countries in collaboration with the government. It's sharing the data from the Global School Health Survey for young people to participate in the process of converting that data to action in collaboration with stakeholders, including teachers and heads of school, principals, etc. And then pushing this effort to integrate these interventions into national policy-making initiatives, policy and program initiatives. A really successful example, at least hearing back feedback from our colleagues, that this has really been a very successful example in a number of countries. Next slide, please. Another example here is collecting data from monitoring. So here is an effort from an implementation research study looking at preventive checkup visits, which has really demonstrates, I think, a very nice collaboration between WHO and UNICEF, an implementation research study that generated a distribution of high burden conditions, including for mental health. So it's a screening plus program with a counseling service and a referral service built into it for younger adolescents and older adolescents in schools and community venues in 3 countries originally, including measures for depression, measures for anxiety and suicide included within the package of screening, and really developed a toolkit that helps to guide countries to scale up these integrated school preventive checkup visits, school and community-based preventive checkup visits, really with the idea of looking at the holistic child, so across a series of high burden conditions that really impact young people, that are delivered, that the service is also delivered with the support of young people. And really taking this initiative and plugging it with this data, using the monitoring information, the monitoring data that's provided, through a process of scaling up across countries. So here is an example of where we've taken the research countries and in fact scaled up to a number of other countries in collaboration with UNICEF. So in Indonesia, for example, we anticipate that this program is providing this service in thousands of schools at the moment. So an opportunity to really translate, to change this data, to move from data to action through a process of using the service data to support countries scale up. And with the idea that, in fact, this will form part of the guidance ultimately on improving adolescent health through what we're calling well care visits across the 10 to 19-year age group. So with that, I'll hand back to Joanna for the final slide. Joanna, over to you.
And if I can just, Prerna was being very humble. This work, I think, is very important that she's been, leading for a long time. And the example of Indonesia that she brought up, the goal, and they are working towards it by next year. They say by end of next year, but I think maybe early 2027, they would have screened all, 7 to 17-year-olds, with this comprehensive health screening check. That's like 53 million students. And that kind of data is not a representative sample. It's like actually the population level data. So I think that those are the types of things we are seeing governments like Indonesia, I mean, it's credit to them, who are moving ahead and just think what you can do in terms of tailoring the program, making investments when you have that kind of information at your hand. So the other thing, and we've been talking a lot about youth engagement, youth leadership in the last few days. And I also want to mention that in the dashboards, in the current dashboards we have too, it was young people who brought up to us. UNICEF has a region called Latin American and Caribbean. And so that was how our data was aggregated. And they said, we don't understand, why would you do that? It's such two different, Latin American and Caribbean. It doesn't give us the granularity. We want to know what's happening in the Caribbean. And so something simple, but so important like that, we have in the dashboard specifically Caribbean as their own region. And, that was a blind spot. I don't know, we had, so involving young people matters a lot for the quality of our work and the product. So just in closing, because these are things that we have not necessarily figured out, but we see as needs going forward. And so with all of you as collaborators too, some of the questions we have are, how is it that we can, and I think this is important, increase that national and global level partnership, that the global guidances and the frameworks, all of these things that we have, how do we make sure that they're really aligned and country owned when it comes to their priorities and using the data? Prerna mentioned, this is something we still struggle with. Yes, we can have the data, but sometimes it's like 2 to 3 years a little late when we can actually use it. So what is it that we can do? It's also a question for the researchers and people investing in data to make these more readily usable for ongoing monitoring and decision making. And the other one is, we are all facing this. We all talked about the need for multi-sectoral integration, but what kind of structure, what kind of incentives do we have that the data can be shared, safely, but also how can we share and work with sectors together in tracking, because these sources of data come not only from one ministry. And then finally, yes, we need to continuing engaging young people in the design and the interpretation and applying the data, which I think others have said, it requires capacity on both the side of young people, both the side of adults, but also institutionalized structures, that it's not just by our own goodwill, but these are things that we can build into the way we work. So the best practices that we have in these are things we ask for collaboration going forward. So thank you very much. And thanks to Prerna as well.
So then, Anna, we need to. All right, I think, thank you. Now we need an Anna. Are you?
Hi.
All right, next slide. There we go. Handing it off to you now.
Thank you so much. And hi, everyone. And thank you for the invitation to join the panel. I'm also really sorry not to be there with you in person. I'm joining you from a very dark London. So good evening to everybody. As Judy kindly introduced me, I'm Anna Zecharia from the International Alliance of Mental Health Research Funders. So we're a global alliance of public, charitable and philanthropic research funders, and our mission is to increase and accelerate the impact of mental health research by identifying kind of cross-cutting challenges that no single funder can solve alone. So I think we're all agreed that adolescent health and well-being is something we've all got a responsibility to come together on, and that continuing to make progress on measurement really is a way to shift the dial. And I think just reflecting that we've heard from a lot of different vantage points in the sector today, and I think I just wanted to underline that measurement is an area where research funders also see significant fragmentation and want to make investments that best support this vision that we've heard for connected and meaningful measurement that we're hearing articulated today. And I'd really agree with Prerna on language. I think the word measurement, it does a lot of heavy lifting. And so developing a sort of shared and where appropriate, more granular language between us, I think could really help shine light on some of these areas that maybe get hidden. So I think what we're doing in the work, and the work I'd like to talk to you about today, is exploring whether this point of language, this point of understanding, whether coming together to explore the connective tissue of measurement, the different needs and uses of measures, whether doing that collectively might actually support some of the great work that we've heard by building that shared understanding and really opening our understanding of where we might need to align for collective action. So I want to talk to you about how we're thinking in terms of the role research funders can play to strengthen the systems of measurement and evidence at all stages and from the beginning. And I think that's the important thing that we're thinking about, which is why I'm framing this as a systems view. So the interconnectivity of the system, I think, is something that lots of people have touched on today. And how doing that can help us build the decision-making structures that we're hearing about. So the whole system helps us see young people's realities more clearly, respond to them more effectively, and hold ourselves accountable for doing so. And I think what we've heard from everybody is that different data sources serve different decisions at different levels, and potentially strengthening that golden thread between them by looking at the whole system is something that could really support that connectivity. So I'm just going to share you through some early thinking today. So next slide, please. So what are we doing? One of our roles as an alliance, I think, is to create space for these multi-sectoral conversations that might otherwise fall into silos, and where sometimes there can be false splits between research implementation and sort of scaling and impact. So through our Common Measures initiative, we know that there's a need for a joined up approach on measurement. And ultimately, I think funders would like to see a measurement system that allows us to direct resources more effectively and evaluate interventions coherently and sort of build that case for sustained investment from the beginning. So as I said, that golden thread is coming through. But when we look across the whole research implementation pathway, which we know is not linear or simple, I think what we've been thinking is that the challenge of what and how to measure, it's not only technical, it's a relational challenge, it's a systemic challenge. So the work we're starting now is about building some shared visibility and communication kind of across this pathway, which I've written out, but obviously is a cycle, and as I said, not a simple one, across the pathway and between all of these initiatives that are already tackling pieces of the puzzle. And it's been great to hear some updates on some of those today. And I think it's important to say that whilst we are focusing on young people in this work in the first instance, I think the things that we're seeing surface speak to the bigger systems challenge in measurement in mental health and well-being. So what we've been doing is some groundwork with funders to scope a kind of loose framing that could help us develop and co-create this sort of shared understanding. We're exploring this in a cross-sector workshop next month on young people's mental health next month. And these are some of the first steps as we kind of continue to bring more perspectives in and hopefully identify some tangible opportunities where research funders can really contribute to this vision. So I guess I'm hoping that this discussion and this session serves as an invitation for you all to get involved and to share your perspectives with us. Next slide, please. So yeah, why are we starting with visibility and communication? And I think that's because building coherence and connectivity across the system, it starts with seeing and hearing each other, with understanding each other. And by raising the visibility of what different groups, and by that I mean young people, of course, but I also mean all the different sorts of decision makers that we've been hearing about today, what these different groups really need from measurement, and communicating and the challenges and the opportunities as they appear from those vantage points, I think then we can start to build this shared picture and this shared understanding of, the perspective of the person that is using the measures. And this is really it's about people as well as about systems. So I think this idea of working together to kind of uncover, where is language hiding something? Where are we apparently talking about the same thing, but we're actually talking about completely different things? I think that won't just help us understand each other, although that would be great. We hope it would also start to surface some of the real blockers and the openings that could help us do things differently together. And the Commission, rightly highlights the need for better indicators and accountability for adolescent health. And I guess from a research funder perspective, we're asking the complementary question of how do we build the measurement systems that can really support those indicators to be meaningful and coherent and usable across research and implementation. What does it mean? And we've heard some of that in the last presentation about thinking about this as a cycle and how each stage of the cycle can build that kind of coherence and the strength that we're looking for. So I think our work is coming from the complementary vantage point of how the research system itself generates and connects that evidence, and ensuring that's coherent, contextual, and ultimately usable, and that we're kind of getting in early enough to build that in early enough to how we think about research. Because as the last presentation kind of highlights, measurement underpins every decision. Supports understanding from a research perspective, reproducibility, knowing where we need to intervene, what's effective. We've heard about guiding program design and development from an implementer perspective, and from a policymaker, investor, and funder perspective, it enables accountability and evidence-based investment. And obviously all of that has to be grounded in what matters to young people. But I think what we're observing through the discussions we've been having with our members, research funders, is that there aren't really clear pathways for this kind of communication between groups, between decision makers at different stages of the pathway. So what we're trying to do, I guess, is just to really zoom out and say, how can we maybe frame this in a way that gives us the bird's eye view of the landscape? Because I think it's a challenge sometimes to balance the depth and the kind of the scale, I guess, the breadth of the picture that we need to hold at once to make progress. So next slide, please. So we've been trying to help ourselves think more holistically about this, and thinking about all of the things that we're hearing in various different decision points and discussions, and to try and organize that into some themes. And those themes are coming through at the moment as meaning, methodology, and stewardship. And this is about us trying to break down, as I said, the big picture challenge into parts whilst keeping sight of the whole. So the questions that are coming through it are really trying to pin down what we really need to measure to make good decisions. And that will change across the pathway and depending on the decision we're talking about. And then once we're clear on what we need to measure, we can look at the tools and where there's a need for innovation or more investment. And then we're thinking quite carefully about stewardship. If we are talking about a connected system, we've heard some great examples of how the system is being stewarded at the moment. But what might it mean? Where might we need shared infrastructure to help us learn together as well? And as I said, we're curious about how these themes are showing up across the research to implementation pathway. And I think critically, like where new insights come from bringing those perspectives together. Because I think that's what we're seeing is rare, that actually people at different parts of the system don't always get the chance to talk to each other. And across those themes, we've got some signals emerging. Some of these have already been touched on, which is reassuring. And I think we're seeing these as signals of where sort of shared attention across the sector could help unlock that understanding. So next slide, please. So something that I think we've heard a lot today, but I really want to stress it from a sort of research end of the spectrum, is that perspectives of young people and implementers are underrepresented. And so constructs like belonging, safety, connectedness, they're important signals of whether something is effective to the people it matters to. And that can be if that's missing from what we're measuring, then we've got a disconnection. And we've also been hearing that it's not only prevalence or outcome measures that matter, but process and impact measures too. But different groups have got different definitions of success and what they need to track impact. And we think kind of teasing that apart would be really, really valuable. And there's also been a sense coming through that we need to be more dynamic as we learn together. And it's been great to hear some more about some of the youth-led initiatives. And funders are thinking about what does it mean to sort of shape this in dialogue with youth as we go. So what does a dynamic learning process look like here? Next slide, please. We're also hearing that there's a mismatch between the individual level measures and system level needs. And importantly, what's feasible or ethical to collect at different points for different decisions. So drilling down on what we really need to know, we can then match the methodology to that. And I think areas like well-being, what we need from prevention measures, and the strength of current approaches also, I think it's not clear. I think there are clearly some strengths, but also, are we having the same conversation when we're talking about prevention and promotion? And I would say we're probably not at the moment. And I think it's also clear that we rely a lot on self-report, and that might mean we're missing the opportunity to measure through other methodologies. And particularly, we're hearing a lot about the importance of qualitative research. And also, we don't know what measures are being used in research by researchers and implementers on the ground in communities, and what we can learn from an approach that is grounded in those contexts. Next slide, please. So I think we're hearing actually the measurement is moving towards being treated as a public good. That is something we collectively fund, govern and sustain, but that we need to balance that with the needs of different contexts. And also there's a lot of positive work going on. We're actually collecting a lot of initiatives that are going on in the measurement space. And one of the challenges is actually how to improve connectivity and communication across those initiatives and see where they are, which problems they are tackling in different bits of the system. Next slide, please. And so we've, as I said, we're coming through doing this initial thinking and framing with research funders, and we're wanting to explore it with others in the sector. So it's really great to be here. And as I said, we're developing a map of measurement initiatives to help with that visibility and communication. So we'll be testing this, as I said, in a workshop next month, and we really want to bring wider perspectives as we evolve this thinking, and to sort of see how, if and how this approach is helpful to others in the sector. So please do get in touch if you'd like to share any reflections on things that I've shared or the approach we're taking. I'd love to hear examples of promising initiatives, because I think we're seeing this as a collective sense-making exercise. So please feel free to get in touch with me directly. Next slide, please. And yeah, I just wanted to end by saying thank you, one, for having me, and two, especially to our funders and partners sort of shaping this work with us. And I just wanted to maybe close by underlying that I think we're coming at this from the perspective of seeing measurement not just as a technical and data systems challenge, but as a relational one. So our goal at this stage is not to try and pin down and define the system, it's to start surfacing these challenges so we can see it together. Thank you.
The US joining us. Oh, the US, our home. I'm Tracy Johnson. For those of you I didn't meet this morning, if you'll pull up my slides. My current affiliations are on the slide, but I'll speak primarily from the perspective of one of the people that uses these data. I heard several of you say, we're trying to picture the person who's using this information. How do they use it to make decisions? So that's what I'm trying to communicate in my presentation. And most of my visuals will share Medicaid generated data, but we use a lot of population health data at the Medicaid agency as well. Some of you presented youth risk behavioral surveillance system data. And these pop health data sources right now are really at risk. If you get bored by my presentation, just Google the website and you'll see a message that says this, there's ongoing litigation about whether this data set will continue to be available at all or in its current form. And so these alternative methods to collect information globally, but having representative samples locally will be really important if it turns out some of these data sets will change substantially. So I'm sure many of you are tracking this, but I just wanted to say it out loud. So turning now to Medicaid data specific to behavioral health, this data is behind, say, primary care data or hospital data for a number of reasons. This is 2022 data, and it's tracking which states collect behavioral health data and for what purpose. Specifically, do they use it for payment? And a few other things. You can look at the slide. And the reason behavioral health data is behind other data is for at least 3 different reasons. You heard my talk this morning, you know that Medicaid programs in different states cover different populations. So there's like some baseline lack of comparability across states in terms of like who's even covered by the program. There were major federal investments in EHR and other health information technology. High tech was one of the big pieces of legislation that behavioral health providers were not eligible for. And so there, at the practice level, systems are much less evolved than many other settings, and it's just more manual for them to collect behavioral health data often. And relatedly, the federal government did not require until recently that behavioral health providers report data in a consistent way, and Medicaid programs report data in a consistent way. And so a lot of what I'm going to talk about is that sort of change. So now, as of 2024, Medicaid programs must report a core set of performance measures. There are a lot of utilization-based measures, so a lot of what the panel talked about beforehand, you will not see in this data set. And but it does create a uniformity across the states. And what I have shared with you here is the child version of this core set. There is an adult version, and there's also non-behavioral health measures. So this is also the 2025 set. I think the 2026 set is out, but since we're in 2025, that's the one I picked. If you look at, you can see a little tiny asterisk next to some of the measures. Those measures are included in another federal data set called the Universal Foundation. So like unlike many countries, we don't just have one way we provide healthcare. You know, we have Medicaid, we have Medicare, we do innovation with our CMMI program, and historically, all these different federal programs use different measures. Now that's less relevant for the population we're interested in, but particularly for adults where there's a lot of overlap, there's been an effort at the federal government to kind of, let's talk about similar things a similar way. And so you can see the overlap in those data sets again by the stars. And then the next set of slides, I'm going to kind of go through these different use cases that are listed here on the right. So this is a public-facing dashboard. A lot of people don't seem to know about it, but CMS produces it, and they report all the core measures plus other measures. They report things like what are the differences between state Medicaid programs. It's a really cool resource that a lot of people do not know about. And the way I, as an administrator, uses this information is I can benchmark my state's performance against other states. And that's really useful if I sort of know I have a problem in a particular area, and I might want to compare myself to other states in the West. Who can pick Colorado? It's one of the square states, rectangle. It's one of those flyover states in the middle. So I might compare myself to other Western states. You know, in this map, the darker color is good. We're looking at youth between the ages of 6 and 17 and getting follow-up care after a mental health related hospitalization. So I can look at in my region, who are the darker color states. I can look at Medicaid expansion states. In the West, there's a lot of states that have not expanded Medicaid to adults. So I might want to look at states I view as peer, or like Colorado compares itself to North Carolina a lot because our delivery systems are similar. And so it just really allows us to kind of find our peer states. So, we may call our friends and say, hey, I have this problem. You look like you're performing better. How do we, improve based on your experience? In addition to benchmarking across states, states are often interested in trending their own performance over time. So this dashboard from Missouri, which is also public facing, because I just literally grabbed it off the website, compares the same measure across health plans and across time. And so the red bars on the lower part of the slide shows you that the health plans all performed worse in 2023 relative to 2022. And so this is something, that would draw the eye potentially of an administrator to say, why systematically across all of our plans are we doing worse this year? What do we need to do to improve? This data is from my home state of Colorado, and it too shows performance over time by health plan. But this measure, again, the same one we've been talking about, is used for payment. So the bottom table shows you which plans performed well enough to earn a bonus and which plans did not, based on whether the text is green or whether it's red. And so you can see in 2020, all red. That's officially and technically calling tanking. So, you may remember in 2020, we were shut down and outpatient clinics were closed. And so that was the primary means and what this measure is counting in terms of follow-up care. But of course, our provider community reached out to us to say, we're following up, we're just doing it about telemedicine. And so we said, okay, let's look at that. So never underestimate the power of a simple analysis. This is the technically easiest thing to run. And this brought tears to my eyes. I mean, look at our provider community. In February 2020, almost no telemedicine. In April, 50 to 60%. I mean, 0 to 60 in a car is good, right? So 0 to 60. So this really was compelling to us for a couple of reasons. One was, we had bonus payment that, according to our own rules, we should not allocate because people didn't meet it, but clearly they were performing. So guess what? We changed our rules. We got it out to the clinics, but also it made us think about our measure. Should this clearly very popular method to reach out to our patients be included in the measure? As you likely know, NCQA eventually recommended this. We eventually did it, but this kind of data, which was kind of underneath the, really thoughtful measure and very simple and probably quite flawed, was still useful to decision-making. And then finally, this was another kind of measure we were using to make a decision where we brought in our university partners. And the visual isn't quite as compelling as it is in primary care, but I'll try to explain what you're looking at. We were hearing from our provider community that, it's much easier for people to attend a telemedicine visit than an in-person visit. And the provider community was servicing this to, make the case that we should continue this. This shouldn't be a COVID-related way to get care, but this should be a forever way to get care. And it was difficult for us to analyze at the state level because with clinics opening and closing, the number of appointments were different over time. And so to really kind of see who's attending and not attending appointments, you had to have that information that was in the EHR and required linking data. And so we went to our university partners, and basically it confirmed the story that less dramatically, weirdly, I think, in behavioral health and in primary care, appointments were better attended via telemedicine. And they did all kinds of interesting sub-analyses. I encourage you to look at the report. But all that to say that many of you are university-based researchers, and there's lots of ways your talents can be used around measurement and around linking data, around doing analysis that can really benefit your friends at your state agencies. So get to know those folks. All right, thank you. I'm just going to wrap up. Yep. And say, and with just a few summary comments, and then we'll hand it off. You could get me to talk about measurement forever, but a few things that I think were really important for us to remember is that the idea of the triangle, like what's the measurement for? What are your indicators for? And there will rarely, I'm not going to say never, I think there will be never, but I will say rarely a situation where one set of indicators or one set of measures are going to be useful for everything that you want to do and every project and everything. And so I think it is really important, and this breadth of presentations talked about the necessity of thinking from the beginning what kind of data are needed and from whom and to whom will they be used. And so it is okay for you not to meet all of the possible stakeholders, but to have thinking ahead of time and bringing in a group of stakeholders, a group of people, including youth, including policymakers, including program staff, whoever are going to need to use the data, they need to be at the table from the beginning to decide together what kind of data will be actually useful. So I think that's part to keep in mind. A second point to keep in mind is that one of the big challenges is that many of these systems take a while to get going, take a while to develop and to get instituted and then to collect the data. And so one of the challenges, and I think one of the things that I think about in terms of the future planning is what kind of data systems are going to exist for us to be flexible and forward thinking to address the changing needs of adolescents. So one of the things, if we think at the ground level that we've been talking about yesterday and today, is like the needs of young adolescents, the needs of middle adolescents, all these different ages, and that those needs change over time. And so whatever we're measuring now may not be the things that our youth need right now. And so how are we going to develop systems that are flexible enough to meet the needs of policymakers and be accessible and useful for and responsive to the youth themselves? And I think that is a tension that is not going away, but that we have a lot of important thought to go into, and the people at the table, the people here, the people who've been here, and the people doing this work are committed to thinking about how do we make actionable, valid, and useful data. And so thank you all for the presentations. I know the folks had to leave early to catch flights, so they apologized. Thank you to the folks who joined us online. And thank you all for listening to our conversation about measurement, because that's what makes me happy.